Hello, everyone, and welcome to today's Adult CLL Chapter event brought to you by HealthTree Community for CLL Program. My name is Kat Richardson, and I am the Education Manager at HealthTree Foundation. I'm very grateful to have each of you here today for your support in building the CLL community. Today's session will be recorded, and the recording will be sent via email to all registrants within 48 hours after the event has concluded. We'll start with a brief meeting tutorial for Zoom for those who are new to the platform. We would love for you to keep your cameras on if you feel comfortable. At the bottom of your screen, you should see the microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. If you are not comfortable being recorded, you are not required to keep your camera on. Your microphone should currently be off and will be kept off by our team throughout the presentation. During the group discussion, you are welcome to unmute yourself once called upon. If you have any questions or comments for us that come up during the presentation, please click the chat icon and type them in the chat box. If you are using a mobile device or a tablet, click on the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the time at the end, we encourage you to do so. If you are using a laptop or desktop computer, click Reactions near the bottom of your screen and click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and click Raise Hand button. And now let's get started with today's event. First, I'd like to thank our sponsors, AbbVie and Genentech, who make this event possible. And the topic for today's event is all about bispecific antibodies for CLL. Here is the agenda for today. I will introduce our speaker, Dr. Adam Kittai. Dr. Kittai will then spend the next 20 to 30 minutes giving us his presentation. After the presentation, we will open it up for your questions and comments. Now I'll take a minute to introduce Adam Kittai. Dr. Adam Kittai from the Icahn School of Medicine at Mount Sinai is a hematologist oncologist, associate professor, assistant director of lymphoma clinical research, and a leader in the CLL clinical research. Dr. Kittai specializes in the treatment of chronic lymphocytic leukemia and Richter's syndrome. He is passionate about guiding every one of his patients through the treatment process, personalizing care to each patient's individual needs. Furthermore, he enjoys developing novel therapies and optimizing regimens. He has had the opportunity to work with cutting-edge technologies and the ability to enroll patients in clinical trials. It's exciting for him to have access to these tools because they allow him the ability to provide the best care to his patients. In the CLL group, he specifically has an interest in developing targeted and cellular therapies to treat this disease. He also works closely with the basic science labs to translate medical advances rapidly from bench to bedside. He is a member of various professional organizations, including the American Society of Hematology, the American Society of Clinical Oncology, and the American Society of Cancer Research. And with that, I will turn it over to Dr. Kittai.
Everybody, it's really exciting to be here, invited by HealthTree to talk about bispecific antibodies for CLL. And so, first, I think I want to discuss what bispecific antibodies are. We'll talk about how they're similar to some of the current treatments available for CLL currently in the clinic and how they are different. We'll talk about the different diseases that the bispecifics are currently approved. Unfortunately, they're not approved for CLL just yet. We'll talk about the various toxicities that we see with bispecific antibodies, and then I'll run through some of the trials that are currently available for our patients with CLL that involve bispecific antibodies. So I'm happy to make this interactive. So if anybody has any questions for me, please let Kat know or enter it into the chat, or just feel free to shout out, put your hand up, and we can call on you live here at this event. So what are bispecific antibodies? And so we've been using antibodies for the treatment of non-Hodgkin's lymphoma since the development of rituximab. So rituximab is an anti-CD20 monoclonal antibody, and obinutuzumab is the same. And the reason why I emphasize the word monoclonal is because bispecific antibodies, as opposed to monoclonal antibodies, bind to two things as opposed to one thing. So how antibodies work is that they are designed to target a antigen, which is something that is hopefully unique and expressed by all the cancer cells, and then target that antigen. So it's kind of like a missile, how I like to explain it. So it's a missile that's targeted against a specific thing on the outside of cancer cells. In the case of bispecific antibodies, it's CD20, which just so happens to be the same thing that rituximab and obinutuzumab targets. So whereas obinutuzumab and rituximab are just monoclonal antibodies against CD20, the bispecific antibodies not only bind CD20, but bind the T cells. So it's kind of like the missile has a load attached to it, something that allows the missile to target the cancer cells, but also allows the T cells to target the cancer cells. And so the reason why this is important is that CLL specifically, and a lot of other cancers, are really good at preventing our T cells from attacking them. And our T cells are integral for attacking cancer. So it's part of our immune system that's an integral first-line defense in attacking cancer. So basically what this does is it's basically a homing device that brings the T cells directly next to the CLL cells or the non-Hodgkin lymphoma cells, allowing the T cells to attack the non-Hodgkin's lymphoma cells. So it's sort of the idea behind bispecific antibodies became started with our monoclonal antibodies, but now they have this new additional effect where they can bring the T cells directly to the cancer, which is why they should be effective in patients with CLL and non-Hodgkin's lymphoma. Now, another modality that you all may have heard about in the area of lymphoma that recently was developed was CAR T cell therapy. So CAR T cell therapy stands for chimeric antigen receptor T cell therapy. And it's also very similar to bispecific antibodies. In CAR T cell therapy, they take out your T cells and then genetically engineer them to attack the cancer. They basically put the homing device on the T cells themselves and then reinfuse them back into the patient, so that way your T cells know where to go. So as you can see here, the bispecific antibodies are very similar to our monoclonal antibodies, but can also attach to the T cells. And they're also very similar to the CAR T cell therapies in the way that they, instead of infused on the T cells directly, they're sort of like a bridge that connects the T cells to the cancer cells. And so bispecific antibodies, once again, can bind to the cancer cells and bind to the T cells, allowing the T cells to attack the cancer cells. So moving forward, the reason why we think this will be effective is because we already have a lot of evidence using the anti-CD20 monoclonal antibodies, rituximab and obinutuzumab, in CLL cells. So really, this is really like those two drugs plus something else, right? And so that's why we're hoping that they'll be effective. The main problem with CLL, as opposed to other cancers, is that CLL dampens our T cells typically more than other cancer cells. The other big thing with CLL, as opposed to other non-Hodgkin's lymphoma, is even though CLL sometimes and usually is considered underneath the umbrella of non-Hodgkin's lymphoma, it's a leukemia, right? So lymphoma is usually a cancer of your lymph nodes, whereas leukemia is typically cancer in your blood. Now, there's a lot of gray in that, where basically lymphomas can become leukemias and vice versa. But CLL is circulating in your blood a lot, as opposed to the other lymphomas, which are mostly in your lymph nodes. And so the reason why I bring up these two facts, the fact that number one, CLL is very good at dampening the effects of our T cells, and also CLL likes to circulate within our peripheral blood, those are two key issues when developing these cellular therapies. One, with the T cells, it's obvious, right? So if you have a treatment that needs to activate the T cells in order for it to work, if CLL is good at dampening the T cells, you might suspect that that particular drug might not work as good in CLL. And the second problem with the CLL circulating in your blood is a little bit more ambiguous. The reason why there was concern there is that, and I'll get to a little bit more about this later in terms of toxicity, is that there was concern that with having the cancer circulating in your blood, it might lead to the toxicity associated with bispecific antibodies and CAR T cells. And so the reason why I'm bringing this up is that currently, bispecific antibodies are not approved for the treatment of CLL. And the reason why it's been taking a little longer for us to get bispecifics in CLL is because of these two main reasons. One, the concern that it may not be as good in CLL because of the difficulty activating T cells. And number two, the concern that it might be associated with increased toxicity. And these concerns were also very valid. And the reason why they were valid is because we saw some of this when we were developing CAR T cells, where, CAR T cells, although originally developed in CLL, took a lot longer to get approved in CLL for these two reasons. And we actually just got our first approval for CAR T cells in CLL with the approval of liso-cel just a month ago. So I'm going to pause there for a hot second and see if there's any questions, because that was a very detailed mechanism talk about bispecific antibodies. So I'm just going to pause for 5 seconds to see if anyone has any specific questions about that. And then we'll move on to the 3 different main bispecific antibodies and the differences between them. Okay, so currently we have 3 bispecifics that have been developed in non-Hodgkin's lymphoma. There is a 4th one that doesn't have approval yet. It's called odronextamab, but I'm not going to talk really about that one right now because we don't have it approved, but I do suspect that it might get approval soon. So the 3 are epcoritamab, glofitamab, and mosunetuzumab. Big words, really hard to pronounce. They all target anti-CD20 and T cells, so they all really work similarly. The difference is how they're manufactured, and I'm not going to get into the differences in manufacturing, but they're all manufactured slightly differently. And because of that, they are given slightly differently. Whereas epcoritamab is subcutaneous, meaning that they just need to poke just below the skin, as opposed to glofitamab and mosunetuzumab are both intravenous, where they have to put a line in your vein to give the drug. And so that's the main difference, I think, between the 3. Mosunetuzumab is actually developing a subcutaneous regimen for itself, so that might change in the near future. Epcoritamab is approved for diffuse large B-cell lymphoma and transformed non-Hodgkin's lymphoma, with a broad umbrella term there. And what's interesting about that and what's relevant to CLL is because epcoritamab is approved for transformed non-Hodgkin's lymphoma, you can actually get it for patients with Richter transformation. So it is available for patients with Richter transformation. You must have received 2 prior lines of therapy for your diffuse large B-cell lymphoma, and currently how it's approved is it's given continuously. And I want you to remember that because that's another big differentiator between the 3. Patients who start on epcoritamab get it until progression. Epcoritamab is given quite frequently, actually. In the first 3 months, it's given weekly. Then it's given bi-weekly, twice a week for months 4 to 9, and then monthly after that. Another key factor with epcoritamab, because there's a high risk of toxicity at your 2nd week dose, you do have to be hospitalized for 24 hours. Glofitamab is also approved for diffuse large B-cell lymphoma, but it's also approved for transformed follicular. So it's a weird distinguishing factor there, but Glofit is actually not approved for Richter transformation. It's also approved after 2 prior lines, and it's given a little bit differently, where you actually receive obinutuzumab first. And the reason why they do that is to hopefully decrease the risk of toxicity, kind of get some disease under control before we give the drug. Then it's given weekly for 3 weeks and then monthly for 12 cycles. So as opposed to epcoritamab, glofitamab is time limited. You only get it for 1 year. Similarly to epcoritamab, glofitamab, you do need to be hospitalized the 2nd week for 24 hours. And then lastly is mosunetuzumab. Mosunetuzumab is only approved for follicular lymphoma, not for diffuse large B-cell lymphoma currently. You must have received 2 prior lines of therapy. It's also time limited, but you can actually stop after 8 cycles if you get a good response, or 17 cycles if you didn't get a great response at 8 cycles. It's also given intravenously. As your doctor, I don't expect you all to know the small intricacies between these 3 drugs. Overall, they have the same mechanism of action. They have a similar toxicity profile, and there are some nuances in how they work in terms of how they work in terms of their efficacy. But we don't have a clinical trial to tell us that one drug is better than the other right now. So in my grand view of things, I think how I approach patients and decide what bispecific antibody to give them for their non-Hodgkin's lymphoma, it really is patient dependent, insurance dependent, priority and preference dependent. But I think that they're all 3 good drugs, and each of them have their own little niche where we use them. Once again, the 4th one is odronextamab, which is not currently approved, so I'm not going to talk about it right now. So the main toxicity associated with bispecific antibodies is something called cytokine release syndrome, or CRS, cytokine release syndrome. Another toxicity that we can get concerned about is neurotoxicity, and I'll talk about that. And last, just like every other therapy that we have for non-Hodgkin's lymphoma, there's risk of low cell counts as well as risk of infection. As a whole, these drugs do appear to be better tolerated than CAR T-cell therapy. The main difference between these drugs and CAR T-cell therapy is that CAR T-cell therapy usually requires a wait of some time. Normally, you have to wait 2 to 3 weeks for your drug to be made. And also, you only get it one time. Whereas these drugs, typically, you get them for at least a year, if not more, but you don't have to wait for them. So that's a benefit to them. So if someone's disease is rapidly progressing, I don't have to wait the 3 weeks for my CAR T to get developed in order to give them an active drug. So kind of some small nuance between those 2 therapies. In addition, there's been some question of whether or not bispecifics work after CAR T and vice versa. And it does look that they do work after each other. So it doesn't really matter if you get a bispecific first and then get a CAR T, or a CAR T and then bispecific first. I will say that there is some nuance to that as well, and we're still trying to sort out some small details there. But overall, the data does appear reassuring that it doesn't really matter which order you get these drugs, but more data and more research is definitely needed. So I started talking about toxicity. I got a little derailed there. Let's move back to toxicity. So the main toxicity that we get concerned about is cytokine release syndrome. So what is cytokine release syndrome? Cytokine release syndrome is basically a side effect of the T cells getting activated. And so in general, when someone gets cytokine release syndrome, it means the drug is working. It's just your body is over responding to the treatment that we give. So typical cytokine release syndrome presents with a fever, but then can progress to low blood pressure, high heart rate, and really can get patients quite ill if we don't do anything about it. Recent guidelines have been published in our main journal, Blood, that have recommended that most cytokine release syndrome can be handled at home. But if you have anything other than a fever or even if you have a sustained fever, getting admitted right away is crucial. So I would say that if you do go on a bispecific antibody, make sure that you have your instructions laid out for you by your doctor about what to do if you get cytokine release syndrome. Oftentimes, we will advise patients to go ahead and take some Tylenol. We might send them home with some steroids to kind of bridge them as they come into the hospital. But for the most part, CRS related to bispecific antibodies can be taken care of at home potentially, but we do have a very low threshold to admit somebody if they get cytokine release syndrome. So if you are going to get a bispecific antibody or CAR T even, just make sure that when you are talking to your provider who's prescribing these drugs, that you have a game plan in case you do develop cytokine release syndrome. Now, to be reassured with the bispecific antibodies, most patients only get either grade 1, which can be managed at home, as we talked about, or grade 2 cytokine release syndrome. And so in the studies that currently we have available for our bispecifics, no one has died from cytokine release syndrome, which is great news. But once again, it can get very serious, and talking to your doctor about what to do if this happens to you is crucial. Now, the next toxicity to talk about is something called neurotoxicity. It's similar to cytokine release syndrome, where it's a effect of the drug just working too well. But neurotoxicity, unfortunately, unlike CRS, occurs in much less patients than patients with CAR T. And so far, it looks like it occurs in less than 10% of patients who are getting bispecific antibodies. Neurotoxicity is in the name. What does it mean? It basically, the initial symptom is confusion, but it can present in various different ways. But basically, patients typically get confused and then maybe even get to the point where they can't be responsive. And so neurotoxicity we take very seriously. And it is a rarer but common side effect to both bispecific antibodies and CAR T cell therapy. Now, the other toxicities that we worry about that I mentioned, infections, as well as long-term low B cell count and cytopenias, those do happen, but in the minority of patients, and we need more long-term real-world data. But I will reassure you that we've given bispecific antibodies to very elderly patients with lots of comorbidities, and they do quite well. So although these toxicities sound very scary, we do have regimens and appropriate protocols that we use to help patients know when to come to the hospital and know how to get the best outcome. So I would say that, we know about these toxicities, we know how to handle them. And as I said, in the trials that led to the approval of these 3 bispecific antibodies, there wasn't any deaths due to cytokine release syndrome, which was great. So moving on past toxicity, I wanted to kind of go through some different trials that we have for CLL. Because as I said, we don't have this approved for CLL yet. We're hoping to get an approval soon. We just got our first approval for CAR T, and there's reasons why that might be. And so the big thing, as we talked about earlier with CLL, is there's circulating disease. And I had mentioned earlier, I would tell you why that's important. And the reason that's important is because the drug is given through your vein or subcutaneously, it gets into your bloodstream first. And if there's a lot of circulating disease in your blood, there's a higher risk of cytokine release syndrome. So that's the concern that we have when patients are receiving these drugs. And then the other concern is, how do you boost the effect of the T cells? So one of the currently run studies is epcoritamab for CLL. And there are currently 4 arms to the study. One is epcoritamab by itself, which is a totally normal thing to do when we're developing drugs, because we don't know how patients with certain diseases might respond to certain drugs. Another one is combining it with venetoclax, and another one combining it with lenalidomide. And there's even an arm that's combining it with standard chemoimmunotherapy. So the reason why I'm very interested about combining venetoclax with epcoritamab and lenalidomide with epcoritamab is there's some thoughts that maybe combining it with either of these drugs might improve T cell function, whether that is because it's better control of the CLL or a direct effect of the drug. But that's kind of the hope, that if you give it in combination, the drug might work better for various reasons, including improved T cell function. So that's one trial that's currently underway. And so I'm excited to see the results of that study whenever it might be available. The next one is currently available for patients with Richter's transformation. And this is a trial that is currently available at Dana-Farber as well as OSU and some other sites. And that's glofitamab by itself, or glofitamab plus polatuzumab, which is currently approved for diffuse large B-cell lymphoma, or glofitamab plus atezolizumab, which is a PD-1 inhibitor. And atezolizumab is also good at activating T cells. So you kind of see a theme here. Lastly, there's a trial of mosunetuzumab, and the combination is either mosunetuzumab by itself or mosunetuzumab plus venetoclax. And I should say, lastly, there is a trial currently rolling of odronextamab for CLL as well by itself. And so there are currently 4 trials that I'm aware of that are in the CLL Richter transformation space using bispecific antibodies, and I'm excited to see the results. So I think overall, where do I expect bispecific antibodies to make an impact for patients with CLL? So currently, CLL has two main classes of drugs that work phenomenally. One is the BTK inhibitors, which is ibrutinib, acalabrutinib, and zanubrutinib, and the other is venetoclax, the BCL2 inhibitor. We have a lot of trials currently ongoing that are either giving these drugs sequentially or combining them that are currently ongoing. But really, the area of unmet need for patients with CLL is after patients have received these two major therapies, because these therapies work remarkably well and are remarkably well tolerated. And so I think that bispecific antibodies are going to be a great option for patients who progress on BTK inhibitors and BCL2 inhibitors. And I also would be excited to use them even after patients have, even after treatments have failed patients after one line of therapy, potentially two, if they have high-risk disease. Because there is some data that shows that using these drugs maybe further into the front line of disease setting might be better because the T cells might be functioning a little bit better because the patient hasn't received so many therapies. So overall, I think all of us in the lymphoma and CLL world are very excited about bispecific antibodies. The keys that we think are great about them is that they are definitely an active therapy in the relapse setting. We can give them immediately. We don't have to wait for anything. And they're also extremely well tolerated. I shouldn't say extremely. They're very well tolerated, and we know how to treat this toxicity associated with them. All of these drugs are currently under development for CLL, and all of these drugs are currently under development, being moved to the front and earlier lines of therapy for patients with diffuse large B-cell lymphoma and other indolent non-Hodgkin's lymphoma. And there's a lot of trials out there that are combining the bispecific antibodies with chemoimmunotherapy, with BTK inhibitors, with venetoclax, and various other things. And so I'm going to end there. And I'm excited to hear any questions that you all might have for me. I'm happy to talk about bispecific antibodies more. I'm happy to talk about CLL in general or Richter transformation. Whatever you guys want to talk about, I'm here, and I'm happy to answer any questions that you have. Thanks for having me and listening to this talk.
Thank you, Dr. Kittai. Let me share my screen again. Okay, it's now time for the discussion part of today's event. As a reminder, you can ask a question or make a comment by typing it in the chat box or by raising your hand if you would like to speak. If raising your hand once you are called on, then you can unmute yourself. And then as questions come in, I had some pre-submitted questions from patients who are unable to attend. You have maybe already covered some of these questions in your presentation, but if you can summarize them anyway, that would be great. One patient wanted to know, how long on average do bispecific antibodies help limit the progression of CLL?
A great question, and unfortunately, we don't have the answer to that question just yet. So currently, bispecifics are being developed for patients with CLL, so we don't have much data in terms of how well they work and also how long someone might remain in remission after receiving a bispecific antibody. I assume that some of these questions might be coming from patients who are on a clinical trial. I will say that, in general, the rule for cellular therapy is that if someone is able to attain a complete response on these drugs, they do quite well. So in general, the better response you have, the longer the duration of response will be, which is what we saw in patients who were treated with bispecific antibodies for diffuse large B-cell lymphoma and follicular lymphoma. But it's really tough for me to guess how long someone might remain in remission without having the data. So I guess in summary, I would say that if you were to get in a good response after bispecific antibodies, that's a very good sign. And I would expect you to have a decent remission, hopefully a couple of years, maybe shorter. It's really hard to guess, and I'm not sure until we see more data.
Okay, perfect. Thank you. And Megan asked in the chat, which is very similar to what I just asked. So if you have anything to add, that's great. But she just said, how long approximately would you anticipate a patient remain in remission following a 1-year course of bispecific antibody?
Yeah, I don't have much to add over what I just said. But I would say, once again, if you get into a good response, it's a really good sign.
Okay, we have a question, and you can go ahead, Paula.
Hi. First, thank you for your presentation. It was very nice. My question is, have there been any long-term side effects that have been reported by patients after the use of bispecific antibodies?
So typically patients recover fully from CRS and neurotoxicity. So that's a really good thing, right? So in general, even if you do get the main toxicities of bispecific antibodies, you do typically respond fully and don't have any long-term consequences. Now, we're still looking at long-term consequences of bispecific antibodies for the most part. So I'm going to extrapolate from what we know from CAR T cell therapy. So the main thing that I think might happen with patients receiving bispecifics that receive CAR T is low B cell levels for a long time and low cytopenias. That might be something that we see, because we do see that with CAR T, and I expect it to be similar with bispecifics for various reasons. It may not be as bad though, because with CAR T you get chemoimmunotherapy and the fludarabine, so it may not be as bad, but I kind of suspect it to happen. So that's something that I would definitely monitor my patients for, is just making sure that they're being careful in terms of infections, that we're monitoring IgG levels to see if we need to give them back IVIG. But I would say low cell counts prone to infection would be a long-term consequence, most likely of bispecific antibodies.
Thank you.
And Alberto has a question. You can go ahead, Alberto.
Thank you. Hello, Dr. Kittai. It seems that the main concern with this type of treatment is the side effects that may happen. So my question is, are there any particularly aggressive type of lymphomas that can benefit from this therapy, in which the use of the medication can be the use of medication could be more important, or I mean, could justify the use of the medication, even though we could expect some side effects?
I would say that these drugs currently are approved for patients who have relapse refractory diffuse large B-cell lymphoma and follicular lymphoma. There's not many good options for these patients. And for the most part, these toxicities are very manageable. And so because of that, it's given that there's not many other options, we know they work in this setting and the toxicity is manageable. I would very much say that in most patients, the efficacy of these drugs definitely outweighs the risk of the toxicity. As opposed to CAR T cell therapy, the toxicity associated with bispecifics, the CRS and the neurotoxicity, mostly the CRS, occurs in only 50% of patients. It's a little bit higher for CAR T. And of those 50% of patients, about half of them will only have grade 1, which, as I said, is very manageable and can even be managed at home in some circumstances. And so we're still working on how best to give these drugs, what the ramp up looks like in terms of increasing the dose to avoid cytokine release syndrome. We're also giving patients steroids much quicker. And we have new drugs in case someone gets admitted, something like tocilizumab, which works really well for this. But I would say that given where they currently are in the relapse setting, the efficacy totally outweighs the risk. I would say that you are correct in that as we move these drugs to the front line, we have to consider the risk and the benefit. And that's part of always when we're developing cancer drugs. In terms of threshold for approval and what we think about risk and benefit, it's a little bit higher for CLL. And the reason why it's higher is because both the BTK inhibitors and venetoclax work really well and are also extremely safe. And so when we think about what a drug might look like that would get into the front line, it also has to work extremely well and be extremely safe, right? So I think that those benchmarks are a little bit different when we think about different types of disease. I think the benchmark is a little bit different, surely for diffuse large B-cell lymphoma. But as it stands in the relapse setting, I think that these drugs work and the toxicity is very manageable.
Thank you. Thank you very much.
And we have another question from Valeria. You can go ahead and unmute.
Thank you. First of all, Dr. Kittai, thank you for your talk. Also, I wanted to ask you after bispecifics, how long do you have to wait to get vaccinated, more or less?
It's a great question. Each institute does it a little bit differently. In general, how I do it, so there's two questions mainly here. One is when do you get vaccinated with like standard flu that you would every year, or if you're due for your pneumonia shot, when do you get vaccinated after bispecifics or even anti-CD20s? I typically don't vaccinate my patients while they're on therapy for sure. And then typically it's about 6 months after they receive therapy. So if you're on one of these drugs for a full year, I would wait for another 6 months before I would give a flu vaccine. Now, that's a little bit of a complicated answer. And the reason why it's complicated is because some patients I still give the flu vaccine to, even when they're on therapy. And the reason that is because even though I don't suspect it to work very well, it's a low risk vaccine and some patients just want to continue with their schedule. And so I think that's also provider dependent, but most likely any vaccine that you receive while on therapy or 6 months after probably is not going to be very effective. Now, in terms of revaccinating patients, every institution is different. We are still working on whether or not revaccination is entirely necessary. And so I will defer that to your specific provider. It's a very complicated question, but it's a great question.
Thank you, doctor.
Thank you. And then Katie asks, is there any way to anticipate who might experience CRS and who might not? Have you seen it in your practice that certain people have more risk factors that make CRS more likely?
Yeah, so one of the things that we always worry about, which is actually plus minus on a lot of our analyses about what predicts CRS. So number one predictor of CRS is where you are in the dose ramp up. So the reason why for epcoritamab, we require a 24-hour hospitalization at cycle 1, day 15, so that's 2 weeks in, is because you're at very high risk for CRS. So that's why we monitor everybody just for 24 hours around that third dose, and that's when we increase the drug to the highest dose. For glofitamab, the highest risk of CRS is going to be at day 8. And so that's why we hospitalize everybody for 24 hours at day 8 for glofitamab. And for mosunetuzumab, the risk of CRS is actually quite low, so there is no hospitalization required. So I know I kind of answered your question a little bit indirectly in the sense that the highest risk is going to be at a certain date when you're receiving a certain dose. And so the dose is actually probably the most potential risk factor for CRS. In terms of disease and patient risk factors, there's a lot of data out there that is looking at this. And one of the things that I worry about with CLL specifically is disease bulk. So once again, if you have big lymph nodes, a lot of circulating disease, I would worry more about cytokine release syndrome. And in general, there are some comorbidities, some other concurrent illnesses that I worry a little bit more about, like renal disease sometimes. And honestly, renal disease is not necessarily a risk factor. It's that if someone has renal disease and they get cytokine release syndrome, it could be a little bit more tricky in treating them, similar to heart disease, because typically the treatment is fluids. There's a lot of fluid shifts, low blood pressure, and so it could just be a little bit harder. And so I would say number one, number two, number 3, number 4, and 5 is going to be the day of your cycle is like sort of correlation with most with CRS. Otherwise, disease bulk is something I look at, and then specific considerations for patients who have comorbidities. The data is still for bispecific specifically. The data is still being worked out for risk of CRS and neurotoxicity.
Perfect, thank you. I think you kind of answered this question, but if you could just review it. Do you know how many bispecific antibody for CLL clinical trials there are at the moment?
Yeah, so I know of 4. Before this, I went on clinicaltrials.gov and did a search. And so that's where I found the 4. So those are the 4 I know of. And then I know personally of a couple of more that are in development in terms of like, they're not available yet, but I know myself and some other investigators have a couple of trials that we have approval from the pharmaceutical companies. Has to go through like regulatory and stuff. So I know that more are going to be popping up in the future.
Do you by chance know what phases they're in? Are they earlier phases or late phases?
In CLL, they're pretty much going to be after one prior line of therapy. It's not going to go to zero for a long time, I think. We need to see more data from the phase 1s and phase 2s before we bring bispecifics to treatment-naive disease. There's sort of a mixture answer. So most of them are after one prior line of therapy, if not two. Getting them back to treatment-naive is going to take some time. If it ever gets there, it's hard to know. And most are going to be phase 2. Phase 3 studies usually require some evidence first to come about from phase 2 before they get developed. So just a quick, what I'm talking about, because I know that I'm talking a little bit high. Phase 1 is first in human, typically, safety analyses. Phase 2 is to look at how well the drug works, like efficacy. And then phase 3 is usually a randomized control trial. So most of the trials currently underway are phase 1 or phase 2.
Okay, perfect. That's very helpful. We have a question in the chat. This patient says, I am on acalabrutinib and venetoclax for 5 years. I am 17p TP53 and unmutated MRD in blood, but MRD positive at the BM. And then she gives a number percentage. Thinking to stop treatment to prevent resistance and toxicity after taking the drugs for a long time. I would like to hear your opinion about that.
So there's one key piece here that's missing. The key piece is treatment naive versus relapse refractory. And I'm going to give you just a patient, like if you were my patient, what I would think about. One thing we can't give here is like direct medical advice. So I just want to say that out loud. So if I had a patient who presented like this is probably what I would do. I do think that if you asked 5 different CLL experts what they would do in this specific scenario, we might give all different answers. So if it's treatment naive, I would stop. I would probably pause therapy and see how you do. In general, the MRD level that you've reached is really low percentage. And so there will be a long time between when you stop therapy and then when you have to restart therapy. So I think that you definitely most likely, a patient like this would definitely most likely relapse at some point, but I think that there would be a nice time in between that we can enjoy a treatment-free interval, especially if you were treatment naive. Relapse refractory gets a little bit more sticky because if someone's relapsed, it's kind of unclear what I would do after this, and the chance of having a long stretch for a treatment free interval is probably shorter. And so if you were relapsed, I would have a kind of conversation about maybe just continuing one of them, acalabrutinib or venetoclax. It kind of depends what you've received in the past. We would have a conversation about how well you were tolerating the drugs. We would also talk about how old you were and what your comorbidities looked like, just in general about thinking about what you might tolerate next. And so it's more of an in-depth patient preference conversation there. But typically I am a proponent of stopping if I can. I think that you can stop in both the treatment naive or relapse refractory. A patient like you could stop in the treatment naive or relapse refractory setting. But it's a very complex, nuanced conversation. And it really depends on what you've been treated before with, how well you're tolerating that combination, and what your expectations are for the future. Now we do have 2 new drugs, just to shout this out from the rooftops. We have 2 new FDA-approved drugs for patients who've relapsed on both a BTK inhibitor and venetoclax. We have pirtobrutinib, which is a non-covalent BTK inhibitor, which is super safe and works really well. We'll see more data on that in the future, but the data we do have shows us that patients who have been treated with a prior BTK inhibitor who relapsed and also got venetoclax and then get pirtobrutinib, it works for close to 2 years, and so that's great. And then we also have CAR T cell therapy, which does induce responses in a subset of patients. And so, and also, as you alluded to, if you do stop, you can also restart, especially if you don't have any resistance mutations and you tolerated the drugs together. So that was a really long, drawn out question, really specific to the patient in front of me. I think treatment naive, I probably would definitely stop. And if it was relapse refractory, it'd be a very nuanced conversation.
Thank you very much. Another question we had submitted by a patient was, do bispecific antibodies work for CLL patients with the deletion 17p TP53 mutation?
So the answer is I don't know truly until we see more data. But I don't see why they shouldn't work. Interestingly about the CAR T cell therapy, and although we still need to see some subset analysis, or I should say just cellular therapy overall, is it may, I say this and it's not entirely right, it's sort of a broad paintbrush stroke, but high risk factors are constantly being reevaluated with our new therapies. And I'm hopeful that some of these new drugs may not be affected by somebody who has high risk disease. And I think cellular therapy might be that. So I don't have a reason why it shouldn't work in patients with TP53 deletion 17p CLL, but we do need more data.
Perfect, thank you. Another question from a patient was about how long does it take for bispecific antibodies to start working?
Yeah, so the time to response when I've looked at it is very soon, usually within the first 1 to 3 cycles. So hopefully that's the same for CLL, but that's what we've seen with diffuse large B-cell lymphoma and follicular lymphoma.
Perfect, thank you. And I have a question kind of about accessibility. So I know you said that for the trials, the patients have to be hospitalized on, I think it was the second cycle 2, day 15 something.
So epcoritamab is cycle 1, day 15, and GlowFit is cycle 1, day 8.
Is that just for clinical trials, or would that also be expected when they're out of clinical trials as well?
It's in the package insert, meaning that it is expected off of clinical trial for you to do it this way. It is not required by mosunetuzumab, so that's sort of a plus for mosunetuzumab. And I know that a lot of my colleagues are working on strategies to not require hospitalization. So usually this happens with new drugs where basically when they're being developed, we're very, very, very cautious in the way that we implement them because you have to really develop a trial that is safe for patients, number one. And then number two, you don't want to necessarily combine a new drug with something else because then we're not sure if the efficacy or safety is due to the drug itself or the thing that you gave it with, right? And so now that they're approved, there are definitely studies currently underway working on CRS mitigation, using various different tools, giving prophylactic steroids. That was a huge thing that changed the way we give CAR T cell therapy. We're very much quicker to give steroids, which decrease toxicity. And also giving new drugs like tocilizumab or cetuximab and various other things, lenalidomide. Even BTK inhibitors have been shown to decrease toxicity with CAR T. And so I know that's something that people are working on because at the end of the day, keeping patients out of the hospital as much as possible is definitely something that we want to do.
Yeah. Do you see patient finances as being a barrier for this kind of treatment? Would that ever get in the way?
Always, right? So, ultimately we're reliant on the insurance to approve the drug. I will say that generally when a drug is first approved, there's a lot of programs through the drug companies that allow for them to decrease the cost of the drug. But ultimately, unfortunately, it's usually dependent on the insurance and whatever programs might be available. One resource for all patients, if you're having difficulty with affordability for whatever reason, I know that the Leukemia Lymphoma Society, the Lymphoma Research Foundation, as well as the CLL Society are good resources. And some of them even have programs, or at least they know of programs, and they have programs that they can put you in touch with to help make the drug more affordable.
Perfect, thank you. And then just kind of my last question. I know you mentioned that steroids is usually the treatment for any toxicity. Is there any other common treatment for side effects of bispecific antibodies, or is it always steroids?
Lots of steroids, and then we use that drug tocilizumab if they're hospitalized. That's typically the combination, steroids and tocilizumab. There are various other things that are currently in development, though.
Perfect. Thank you. And I think we'll end the discussion there. And I wanted to inform everyone of the free resources available for you in HealthTree Cure Hub. Securely connect your medical records and track your CLL labs in one place. Accelerate CLL research by participating in surveys, find clinical trials, and side effect solutions. Access your free HealthTree Cure Hub account by visiting the link at the bottom of this slide. I'd also like to mention our next CLL webinars. On May 30th, oncology registered dietitian Joan Elizondo will discuss dietary guidelines for cancer prevention after treatment. And then on June 26th, Carrie Rogers will be discussing relapse refractory CLL treatment options. To register for one or more of these upcoming events, you can also visit the link at the bottom of this slide. And again, thank you to our sponsors, AbbVie and Genentech, for sponsoring this event, and it would not be possible without them. Thank you, Dr. Kittai, for your presentation and discussion. We really appreciate it. And thank you everyone who joined for helping us create a HealthTree community for CLL. I appreciate you and hope you have a great rest of your day. Please don't hesitate to reach out if you have any questions about HealthTree or upcoming events. Thank you.